Ladies and gentlemen, a very warm welcome again on the next edition of the Sleep of Science series. My name is Jörg Molnar. I'm the head of the Department of Anaesthesiology and Intensive Therapy at Semmelweis University. We are organizing this webinar in collaboration with the Translational Center for Translational Medicine. And this is my good friend Attila Martel, who is helping us with all the technical details. And you may notice that we switched the venue because we are now in a small studio because we are having a celebration downstairs in our usual setup. This is the third progress report of the first year PhD students. There are about 100 of them. And this is the first day, so they are having a very busy time down there giving lectures. So now we are squeezed in here, but no worries. The previous webinars have been watched by almost 400 people now on YouTube. So I'm absolutely certain that our current guest, Konstanty Szułdrzyński, a very good friend of mine, a SEPS East founder and collaborator from Warsaw, initially from Krakow, and from Warsaw, who is also very well attached to all kinds of international societies, most currently the Euro also, am I right, Konstanty? And he will talk about one of his favorite topics, the lung and the diseased lung, and in fact, understanding the EQ matching in respiratory failure. So Konstanty, thank you very much for accepting our invitation, and I hand the sound and the picture over to you. So please proceed.
Thank you, Joel, very much for this kind invitation and this kind introduction. I'm, in fact, the head of the Department of Anaesthesiology Intensive Care at the National Institute of Medicine in Warsaw, and we've been collaborating for many, many years within SEPS East, this famous Central European cooperation for knowledge and training in intensive care. So mechanical ventilation, respiratory management, and respiratory failure are my favorite topics. We started doing ECMO nearly 25 years ago, but there is no ECMO and there is no appropriate mechanical ventilation without understanding of underlying physiology. And in fact, when we deal with a patient like this, who has very little aerated lung left for mechanical ventilation. Here you can see this is the amount of aerated lung that can be ventilated. Then we encounter a serious problem how to protect the lung and maintain adequate gas exchange to support the patient and to keep the patient alive and let the lungs heal. So the concept of baby lung was conceived in late 80s. Baby, why baby? Because it's compared to the size of the lung in a baby, but it's definitely not sufficient for an adult. What is the baby lung? The baby lung, in fact, is the aerated lung. It's the aerated lung that can be ventilated during ARDS. And in fact, in the very beginning, as you probably remember, ARDS as a syndrome was described in 1978. So in 70s and in 80s, the main focus was on gas exchange, because to keep the patient alive, we have to maintain gas exchange. Then everything gradually changed toward more lung protection. And now we are here, we are concentrating on lung protection. But still, we should not forget about gas exchange, because gas exchange is what the lungs are designed to provide, and without proper gas exchange, you cannot keep the patient alive. So we need gas exchange and lung protection at the same time. So let's focus on gas exchange, because everybody understands from our university that gas exchange is based on diffusion and ventilation, and it's necessary to provide ventilation to perfusion matching. Without ventilation perfusion matching, there is no appropriate gas exchange. Therefore, we can encounter two types of problems. One of them is shunt. What is shunt? Shunt is when the blood flows through poorly ventilated or not ventilated parts of the lung, so there is a venous admixture because there is no addition of oxygen in these parts of lung, and it's mixed with oxygenated blood. This oxygenated blood travels through well-ventilated and aerated parts of the lung, and the net result is the decreased oxygenation because there is an admixture of venous blood, right? So when you have a lot of collapse, atelectasis, then you get a lot of shunt, okay? And on the other side, there is a different phenomenon, and this is dead space ventilation. Yes, in some parts of the lung, there are alveoli that are ventilated, better or worse, but still ventilated, but there is no blood flow or very, very, very little blood flow. And the net result is that there is no venous admixture, but there is wasted ventilation because the part of the ventilation that goes into poorly perfused lung is called wasted ventilation. Right, so let's talk about shunt first. Shunt can be calculated. This is capillary oxygen minus arterial oxygen divided by capillary minus venous oxygen content. For sure, we cannot measure the capillary oxygen, but what we can measure, maybe not measure, we can calculate the oxygen content within the alveolus with the gas equation, and this can be calculated. So what you need is mixed venous blood gases and arterial blood gases, and then we calculate the alveolar oxygen concentration based on FiO2. It's important to remember that up to 50% of blood flow in ARDS patients goes into lung collapse regions, and that was described, sorry for the format, it was cut somewhere here, but this is the paper from 1979, so 1 year after ARDS was described, and this was a study in nearly 180 patients. So they proved that nearly 50% of pulmonary blood flow goes into non-ventilated regions. So how to keep the patient alive? Because even if you increase the oxygen content, you only reach the regions of the lung which are well ventilated, and you cannot increase or improve oxygenation and gas exchange in collapsed lung. So sometimes you don't even have to calculate the shunt, the amount of shunt. It's enough to see that when you increase the oxygen, the response in blood saturation is not so prominent. So you increase oxygen and you get no saturation improvement. That means that you have a lot of shunt. What are the reasons for that? So the first is collapse, and the second is the impairment of hypoxemic pulmonary vasoconstriction. As you probably all remember from physiology lessons, there is something called Euler-Liljestrand reflex, which is designed to provide ventilation to perfusion matching by vasoconstriction. So the vessels, the arterial vessels, constrict in the regions of lung that are poorly ventilated, resulting in hypoxemia in the capillaries. So when there is hypoxemia, there is vasoconstriction. So this mechanism should redirect flow to well-ventilated regions. The problem is when there are no well-ventilated regions, such as in severe ARDS. On the other hand, when the patient is in very high inflammatory status, these inflammatory cytokines and resulting endothelial dysfunction may impair hypoxemic pulmonary vasoconstriction. So there is no flow redirection, and the flow goes directly in these inflamed and collapsed regions, unfortunately. Another issue that can be the reason for intrapulmonary shunt can be microangiopathy by thrombosis, which we encountered in particular in COVID-19 patients. Microthrombosis in parts of the lung led to redirection of the flow into poorly ventilated parts of the lung. And sometimes you could see in these patients very little opacities in CT scan, but very, very poor oxygenation that resulted from VQ mismatch. Another problem are anatomic intrapulmonary shunt, because there are anatomic anastomosis between arterial and venous side of the pulmonary circulation, which should not be patent. So there should be very little flow in these anastomoses. However, this flow can increase significantly, especially in hyperdynamic circulation, such as in patients with sepsis, which also allows us some field for manipulations with pharmacology. And last but not least, we can increase shunt by our manipulations with mechanical ventilation. If we increase intra-alveolar pressure, we can redirect the flow, but we'll cover this topic a bit later. Please do not forget that increased pulmonary vascular resistance leads to reversed flow through patent foramen ovale in up to 20% of ARDS patients, and this can be a significant reason for venous admixture, but it's not pulmonary. This is cardiac admixture of venous blood appearing in up to 1/5 of these patients. So this can be quite significant. Another problem, as mentioned, is physiologic dead space. This is the part of the lung that is ventilated but poorly perfused. So this is also called wasted ventilation, because this is the ventilation that is not used for gas exchange. Here you can see the easiest description of dead space. This is -1 minus end tidal CO2 divided by arterial CO2, and this is the easiest way to calculate it. There is some part of anatomic dead space, and these are the parts of the airway which are not involved in gas exchange, and also physiologic dead space, which arises from poor perfusion in some parts of the lung. There are various formulas how to calculate it. And as you can see in this paper, there is very elegant paper, and they are all described with their upsides and downsides of every formula. But it seems that the easiest part is the last one proposed by Gattinoni, and this is just the division between end tidal CO2 and arterial CO2. It's not the precise measurement, but it gives you some kind of idea, as you can see here. And the parameter that can be quite easily calculated is the ventilatory ratio, which in fact is the proportion of actual alveolar ventilation compared to predicted ventilation, provided there are ideal conditions without any dead space ventilation. So ventilatory ratio is getting more and more popular. However, as you can see, it's not so easy to calculate. It was proven nearly 20 years ago, or over 20 years ago, that in fact not oxygenation, but the amount of dead space ventilation is indicative of the mortality risk in ARDS patients. Because for every 5% increase in dead space, the odds of mortality, increased by 45%. So this is a lot. 5% increase of dead space ventilation results in 45% increase of the risk of mortality. So this is a lot. How can we improve it? How can we manipulate it to improve it? There were some trials to use pharmacology. For example, it was observed that catecholamines induce opening of anastomosis and increase intrapulmonary shunting. It's quite interesting, in fact, that norepinephrine contributes to increased shunt in much more extent than vasopressin, for example. So it could be that in ARDS patients, we should use vasopressin rather than norepinephrine. Unfortunately, we don't have any strong data supporting this thesis, but there is some impact of catecholamines on pulmonary circulation. So they sometimes tried to use, for example, beta blockers. And in fact, administration of beta blockers, such as in this quite old trial from mid-80s, what they obtained was increased oxygenation and dramatic decrease in venous admixture by administration of beta blocker. On the other hand, even if you increase oxygenation, so oxygen content in the blood, you decrease the cardiac output, and overall result is decreased oxygen delivery. Because our main aim and our main goal should not be perfect saturation, but it should be the oxygen delivery to the tissues, in fact. So probably it's interesting, but not very useful in these patients. So another approach is to use inhaled nitric oxide. And this inhaled nitric oxide, as you can see, it can relax smooth muscles. It can increase the diameter of capillaries and capillary blood flow. And as it is, it reaches only well-perfused, well-ventilated alveoli, it opens circulation in the regions which are well ventilated, thus improving ventilation to perfusion ratio. So the main goal is to redirect flow to these areas which are well ventilated. And it was proven for many, many times that administration of inhaled nitric oxide can improve oxygenation and can also decrease pulmonary vascular resistance. However, we do not have strong data supporting use it based on improved survival, at least not so far. It's quite interesting that if you increase the availability of nitric oxide by delivering it, for example, orally or intravenously, it does not improve oxygenation, which is quite obvious because what you should do is improve perfusion in these regions of the lung which are well ventilated, and in this way you should improve ventilation to perfusion matching. So using, for example, sildenafil does not improve oxygenation in ARDS. So what about the impact of mechanical ventilation on ventilation to perfusion matching? It was noted quite early during the course of the pandemic that doctors encountering very severely hypoxemic patients tended to use high PEEP. And it was observed quite early that it's not necessarily always a good idea. Why not good idea? Because increased PEEP resulted in more dead space according to Enkhoff calculation or Bohr calculation. Every time increased PEEP levels resulted in more dead space. So it's inevitably increasing dead space when you exceed certain levels of PEEP. Why is that so? Look at this study. It's very interesting. These are pictures taken of the dog's lung. It was from Göran Hedenstierna's lab in Uppsala. And this dog was ventilated with no PEEP, and this dog on the right was ventilated with PEEP. And look what happens to the capillaries. These are erythrocytes within the alveolar capillaries. Here you can see capillaries surrounding the entire alveolus. Whereas when you administer some positive and expiratory pressure, what you get is total collapse of the capillaries in the alveolar walls. And all that is left is the flow in so-called corner capillaries, and result is decreased diffusion area and increased blood speed here. So you have much less diffusion in this way by concentrating this flow in these corner capillaries. So when you administer too high PEEP, what you get is hyperinflation in well-aerated regions, right? And when you hyperinflate these well-ventilated regions, these high-compliance regions of the lung, the result is that you redirect the flow in the opposite direction. So you redirect the flow into the collapsed regions, which decreases VQ matching. It's very bad for VQ matching. So the net result of increasing the PEEP is increased intraalveolar pressure, right? And this leads to the closing of capillaries and flow redirection into corner capillaries, but also to flow redirection into other lung regions, also to the collapsed lung regions where there is no ventilation whatsoever. It's also interesting that when you have one-sided pneumonia, for example, which cannot be recruited, because even with very high pressure, you cannot recruit pneumonia entirely. You can try to recruit ARDS, but not pneumonia. Then you redirect the flow into the diseased lung, because you hyperinflate the healthy lung because the compliance is better, and then you redirect the flow back to the site of pneumonia, thus decreasing VQ matching again. So please keep in mind that even though PEEP tends to improve oxygenation, it can lead to redirected flow, increased shunt, and for sure it can lead to increased dead space ventilation. So how to set PEEP? There are different types of PEEP setting, the different types of approach to type setting. For example, these famous ARDS network PEEP FiO2 tables, for example. But it was quite interesting that this meta-analysis of combined patients from LOVES and EXPRESS trials revealed that, in fact, increased PEEP improved survival only in those patients in whom increasing PEEP improved oxygenation. So if you increase the PEEP and it improves oxygenation, then you probably help the patient. But if you increase the PEEP and you don't get improved oxygenation, then you probably do not help the patient or even harm the patient. This is quite interesting, quite old study performed in China, which compared different approaches to PEEP titration. And look at this. This is the point of best oxygenation, best PF ratio, and this is the point of best compliance. And if you compare it, you can see that the least amount of dead space is somewhere here. So somewhere where you get the best compliance, but not the best oxygenation. So should we base our PEEP setting on oxygenation or the compliance? Unfortunately, there is no data from any trials, and this is very interesting from this quite old review from Current Opinion in Critical Care by Luciano Gattinoni and his friends, saying that best PEEP does not exist. So we should balance between improved oxygenation versus increased dead space, and also take into account hemodynamics, because there is nothing like optimal PEEP. There is probably some kind of better PEEP, but we always have to sacrifice something. So we sacrifice dead space for the sake of better oxygenation, and we also impair circulation. So there is probably no optimal solution. However, there are some solutions which can be more useful than others. For example, this is electrical impedance tomography. And with these novel machines, we now have two machines like this. They have the function of perfusion. So they can measure the distribution of ventilation. As you can see here, this is where the ventilation goes, right? So there is ventilation, and there is also distribution of perfusion. And when you overlap these ventilation and perfusion maps, you get something like this. So green means that in this area, you should basically have appropriate matching of ventilation and perfusion. Whereas in these red areas, you have predominant perfusion with probably poor ventilation. And in these blue areas, you have more ventilation than perfusion. However, the relationship between these blue areas and the real dead space, it's not so straightforward. It's not so easy to explain, but it helps you, especially because you can compare it. As you can see here, you can see the ventilation, the distribution of perfusion, distribution of ventilation, here divided in quadrants. Here you can see it's quite similar. So this is good matching. However, it's not so good in all the patients. This machine also helps you to determine the optimal PEEP. And what is also interesting, that putting the patient in prone position is probably the most powerful, the most potent method of improving VQ matching, because by proning the patient, you homogenize ventilation, you improve the ventilation, especially in these dependent regions. However, the perfusion remains more or less the same in dependent regions, and you do not impair these the circulation in dependent regions, because there is a larger number of large bore capillaries. So what you get is better ventilation to perfusion matching by redirection of ventilation rather than perfusion. And it was also studied during COVID pandemic. As you can see, in this patient, you have a lot of ventilation with poor perfusion in supine position. And when you put this patient in prone position, it's gone. You don't have this blue region of ventilation without perfusion. So changing the body position can help, as you can also see in these patients, where here you have in prone, you have much better matching compared to this. Here you have the regions of very good ventilation with very poor perfusion, and very good perfusion without good ventilation. And here you have much better matching of ventilation to perfusion. Quite interestingly, our friends from Prague, they are working on side positioning of the patients, and then they prove that you can redirect the ventilation into one lung, especially from the healthier lung to the more diseased lung. You can avoid hyperinflation of the healthy lung, and then it's not published yet, but they also showed that you can improve VQ matching. So you don't necessarily need to prone the patient. The lateral turning of the patient is sometimes effective, especially in one-sided pneumonia, for example. So here you can see the VQ matching depending on prone or supine position. Here you can see that you have much better distribution of ventilation and perfusion in prone position compared to supine position. But look what happens if you increase PEEP in this patient. Here you have absolutely no ventilation. You increase the PEEP and you get the ventilation. There was perfusion. So there was definitely some shunt because there was perfusion and no ventilation. And by increasing PEEP in this patient who was apparently a recruiter, you could improve this ventilation to perfusion matching. However, you lose ventilation here. It's probably due to hyperinflation in this region. So just to remember, VQ matching is in fact the ultimate goal. We concentrate on what we get on the ventilator, but it's not only the ventilation that matters. It's also where this ventilation goes and what are the hemodynamic consequences of mechanical ventilation. So please keep in mind that the ultimate goal is improving the VQ matching. Please remember that mechanical ventilation does matter. It does matter for the patient's safety. It can damage the lungs, but it also impairs VQ matching in some patients. There are some pharmacological interventions, and probably the inhaled nitric oxide is the most effective and probably the most beneficial of them. Prone position acts as a very potent, very effective means of VQ matching, but also lateral positioning seems to be quite effective, and you should measure it. Try to measure it to understand it because it's really, really important for our patient. Thank you very much.
Thanks a lot, Konstanty. Great summary. Unfortunately, as I mentioned at the beginning, it's only us here in the studio, so it's going to be a one-on-one conversation now. But just for those who are online, please do not hesitate to ask any questions in the chat. We can reveal those, and Konstanty can answer them. So I was absolutely intrigued by your last bit of your presentation, using the Timpel. So do you have it in your daily practice?
Yeah, we have it, and we use it.
Machines, you said. You have two machines now, right?
We have one machine, and we are acquiring another machine. The problem is that the perfusion is still not available for clinical practice, so you should sign an NDA that you use it for research purposes. But it's very effective, and it gives you a perfect idea of this VQ matching.
How does it measure perfusion?
It's quite
obviously it doesn't measure, it estimates it, but how?
No, it in fact measures it because you can. It measures, but not the absolute value of perfusion. It measures the distribution of perfusion. So it tells you where is more perfusion or less perfusion. How you can do this? You administer 10% saline, which decreases impedance suddenly. And when you filter out the ventilation, what you get is the perfusion pattern.
All right. Very clever.
It's very clever, yes.
Yeah. I mean, from the safety point of view, do you believe that this type of technology will become a standard monitoring of ventilation?
It's very safe. It's completely the name suggests some associations with electric chair, but it has nothing to do with electric chair. So it's completely safe. It's not electrocution.
No. Yeah. You misunderstood me. I thought that because our ventilation, mechanical ventilation, can do harm.
Yeah.
So to avoid harm and to optimize VQ ratio, doing this continuous monitoring, visualization of the lung, will this become a standard monitoring?
It's a perfect point, because what you mentioned is this continuous monitoring, and it's unlike anything else. Nothing else can provide you with the real-time data on the distribution of ventilation. Because, for example, our nurses start to use it because if they can see that something is getting worse, for example, ventilation in one quadrant, they do suctioning of the patient, and then they change the patient's position. And they can do this right away. And if it doesn't go away, they call a doctor. So you can detect pneumothorax quite rapidly and quite timely, in fact.
Oops, we have one question. Let me just see that one. Could you explain for us how can we imagine the releasement of chronic hypoxemic vasoconstriction and vasodilatation causing shunt? I don't know the word releasement. Possibly imagine the assessment. I don't know. Do you understand the question?
How can we imagine? The problem is
I can't imagine the excessive oxygen reaching the vasoconstricted area when that alveoli is chronically underventilated. Thank you. So let me read it again. Could you explain for us how can we imagine the releasement of chronic hypoxemic vasoconstriction and vasodilatation causing shunt? Releasement when COPD patients receive oxygen. Or releasement. It would be difficult for me to answer that question. Do you have any idea, Konstanty?
I'm trying to figure out what the anonymous attendee means. I guess the question is why in the patients who are generally poorly ventilated, right? Because you have elevated CO2 in these severe COPD patients, you have generally poor ventilation, and how can you decrease vasoconstriction by administration of oxygen? Yes, this is true. The ventilation of these regions is generally decreased, but not to that extent that the oxygen does not reach these alveoli. The oxygen does reach these alveoli because if you administer oxygen to patients with COPD, what you get is increased saturation, right? So if you increase the saturation, it means that the oxygen reaches the alveoli, which are, at least get some ventilation. And it can counteract the vasoconstriction in these regions. You probably do not necessarily need to reverse vasoconstriction in all the lung regions in COPD patients. It's enough to decrease vasoconstriction, at least in some part of the lung, to decrease the pulmonary vascular resistance in sufficient way, as most of clinical trials show that administration of oxygen can decrease the risk of cor pulmonale in these patients.
And we have to be more forgiving with the PaO2 value in these patients, right?
Provided we do not decrease the respiratory drive, yes.
Yeah. I can't see more questions, but you did not touch the process of lung recruitment to improve ventilation perfusion, apart from proning. Proning is a way of recruitment, but
Yes.
so I have two questions. What do you think about lung recruitment? If you use it, how do you do that? And what is your threshold when to prone your patients?
In fact, you can see this in this part, because what you get in people of 15 centimeters, in fact, is recruitment. Because you probably, even if you do not perform a recruitment maneuver, after some time, you get some recruitment with increased PEEP. And in fact, you get better matching after recruitment, provided the patient is recruitable. So if there is no recruitment, you do not improve VQ matching. And if the patient is recruitable, you improve VQ matching, as you can see in these patients in whom after the recruitment maneuver, you have better oxygenation and better compliance, because better compliance basically means less dead space ventilation.
So, yeah, I mean, the way I do recruitment is exactly what you're saying. I increase the pressure, 30, 40 centimeter of water. And if there is improvement or no change in compliance, but there is improvement in saturation, I know that the lung is recruitable. If I see that deterioration that you depicted we lose the capillaries, we lose perfusion, then I see a sudden drop in saturation and deterioration in compliance. So what is your threshold? When do you prone your patients? What FiO2, what PEEP, or what is your strategy to prone your patients?
It's much easier with electrical impedance tomography, because with electrical impedance tomography, if in the dorsal half of the lung you have less than 45% of ventilation, then the patient usually benefits from proning. So if you have this significant imbalance between ventral and dorsal ventilation, then proning usually helps in these patients. But regarding the recruitment maneuver, I believe that it's worthwhile to perform at least one recruitment maneuver. And if the patient turns out to be recruitable, then you can keep repeating the maneuvers. If the patient is not recruitable, then repeating this recruitment maneuver is probably harmful. With EIT, you can see very nicely the amount of air, this is so-called basic impedance of the lung, if it decreases over time. So if the amount of the air in the lung decreases over time, it means de-recruitment is going on. And if you can see this de-recruitment happening over time, what you can do is perform a recruitment maneuver and then return to higher PEEP. And when you get this line constant and flat, when there is no de-recruitment, it means that you have appropriate PEEP. And this is very, very elegant because you can see it real time.
That was a very elegant presentation, Konstantin. Thank you very much. Any last remarks from your side?
No, pleasure to see you, as usual.
Yes. So thanks very much for all of those who stayed with us online. And we will distribute the link of the video of this webinar as soon as Attila prepares the final version. And we'll share it on the Mentor Halo and our mentoring network, and also on LinkedIn. So thanks especially to you, Konstantin, for joining us and taking your time and effort to tell us all these very exciting issues about VQ matching. And for the others, have a nice evening and see you in 2 weeks' time with Jan Bakker. Thanks a lot. Ciao.